Good day, my friends. I'm quite excited about this. Today on the show, we have Dr. John Neustadt, who is the author of Fracture Proof Your Bones. We're going to be diving into everything about bone health, what goes on in your bones, how do we keep them healthy, how can we reverse osteoporosis or osteopenia, how can we prevent getting there in the first place. Dr. Neustadt founded the Montana Integrative Medicine Clinic in Bozeman, Montana in 2005. He's the founder of Nutritional Biochemistry, a dietary supplement company. He is a wealth of knowledge. He's published more than 100 research reviews and written 4 books. So y'all know kind of my history of going through this book writing process. So I really appreciate his resilience in pushing through and getting this information out to us so we can benefit from it, and how important this concept of bone health is to every area of our life. So please enjoy this show with Dr. John Neustadt. All right, Dr. John Neustadt, welcome to the Pain and Performance Podcast. Thanks for joining me.
Thank you. This is going to be fun.
Yeah, I'm very excited. This is one of those topics that, like, on the surface, you talk about bone health and we talk about, preventing fractures and all that stuff. And I think some people kind of, might glaze over a little bit, although I hope we are starting to learn how important this is. But it's one of those lead domino topics that really has so many downstream implications once you start actually paying attention to all the moving parts of getting our bones healthy, preventing fractures, preventing osteoporosis. So I'm quite excited to dive into some of this stuff. So let's do this. Let's lay the groundwork for some of this. I'd like to kind of set the stage a little bit for the depth of what this means for people. So if we're talking about the consequences of bone health, what are the main consequences of not having healthy bones?
So the major and the most important, I think, is dying. This really is a situation where if you fracture a bone, if you fracture your hip specifically with osteoporosis, there's up to a 36% chance that you're going to be dead within a year. And then it gets into disability, to lack of enjoyment, chronic pain. Those people who survive, about half of them never regain their pre-fracture level of mobility, pain-free lifestyle, allowing them to enjoy everything that they enjoyed before breaking a bone. And even before, an overt, what we would call a clinical fracture or a major osteoporotic fracture, it can cause pain in the bones if there are microfractures, small little cracks that are starting to develop that can limit people's mobility and again, the ability to just enjoy their lives.
Yeah, I think people don't sometimes realize how much like bone health and fractures are related to mortality. I'm with you. I pulled a bunch of research on mortality rates for this, and you see everything from, like you said, 15 to 35%, even starting at like 60 years old, which is like you are extremely young, and yet our survivability, a year, 3 years out is quite scary in a lot of cases.
You're right. There is a range that's in the research. So typically, you've said, 50 to 35. I've seen 20 to 35, 36. I tend to quote the higher end of that number because for a couple of reasons. One, it really drives home the severity of this. And I want to highlight to people how important this is to pay attention to this disorder and this disease, which is largely preventable and reversible. And in fact, in men, the risk of mortality is about double what it is in women, because as people get older, and this is primarily a condition that affects people as they age, as they get older, the comorbidities, the other heart disease, diabetes, those tend to be more severe in men, and having other health issues, just like it increases the risk from dying from COVID, also increases your risk from dying from a fracture. And to just drive this point home a little bit more, how common this is, how dangerous this is, that for women 45 years old or older, their risk of getting an osteoporotic fracture is equal to their combined risk of breast, uterine, and ovarian cancer. And so it is something that is common, it's serious, and I'm hoping that people will pay more attention to.
Yeah, and certainly I want to we'll kind of put a pin in the reversible and preventable conversation for just a minute as we I guess talk about the different parameters of this. Can we kind of take a little step back and go through like what bone is and how that kind of whole process works? I think a lot of people think of bone as this like, what we see, this hard, like dead, hard object, and it's this living, kind of changing tissue in our body, but I don't think we think of it like that. Can we just do a quick little overview of bone, kind of cell health and how bone is actually made?
Absolutely. It is a living tissue and it is miraculous. It does provide structure so we can walk and jump and sit down, stand up, hug our loved ones, do all the things that we enjoy. But it is alive. You are constantly getting new bone being created and old bone being broken down, and two cells are responsible for that. The osteoblasts build new bone, and the osteoclasts break down old, worn out bone, so fresh, healthy bone can be created. In fact, about every 10 years, your bone is completely turned over. You have new bone. And it's more, though, than just the mineral content, which is what gives it its hardness. And that's what the bone density test measures, only the minerals. There's a, frankly, more important, or I would say at least equally important, when it comes to fractures, it is more important, component of bone, and that's the extracellular matrix, the proteins in bone, the collagen in bone. There's bone collagen, which gives bone its strength and its flexibility. Bones are hard, but healthy bones are a little flexible. And collagen, if you're familiar with that protein, is all throughout our body. There are lots of different types of collagen. It gives elasticity to our skin. When you pinch your cheek and it bounces back, it provides for the bone that elasticity as well, so that if you fall, the shock of that impact can be absorbed over a larger volume of bone. The bone can deform just a little bit and not break. It's not brittle. It gives bone its quality. And in fact, the tensile strength of strand for strand of collagen is stronger than steel. The minerals bind to the collagen and the extracellular matrix, so they're intimately connected, and both are important. But it's that extracellular matrix and the protein in bone that is often overlooked when people are discussing bone health and what is bone. But it is much more than just a structural component with proteins and minerals. Bone as a living organ produces our blood and is a part of our immune system. So it produces our red blood cells, our platelets for healthy blood clotting, and our white blood cells for a healthy immune system. And research over the last about 10 years have uncovered a vital and important role of bone in our endocrine system. It's also an endocrine organ. It produces some hormones like osteocalcin that helps with blood sugar regulation. It's involved in male fertility. It's involved in brain health and cognition. So bone is touching other structures and other tissues throughout the body, but also it can produce oxytocin. Osteoblasts can actually produce oxytocin, which is our love hormone. It helps us feel connected. And it has serotonin receptors. It has melatonin receptors. Bone is a beautiful, complex thing that's intimately integrated with everything else in our body.
I didn't realize the depth of that. I mean, I've been studying a lot about bone over the last couple of weeks, but that even leads me further into my thought that this is like a huge lead domino. If you start paying attention and doing the things right to get your bones healthier, like that will filter out into every area of your life, it sounds like.
Absolutely. And in my book, when I help people walk through to create a holistic plan for themselves, I comment on exactly that. You're right. that when you do things that are healthy for your bones, diet, lifestyle, exercise, those are also prescriptions that will help reduce your diabetes risk, cardiovascular disease risk, dementia risk, risk of mortality, and on and on and on. Absolutely.
Let's go back to the minerals for a second. So, when we look at the minerals that make up bones, calcium obviously comes to mind for
Mhm.
everyone. What are the other things that are wrapped in there that are in that extracellular matrix?
There's magnesium, there's zinc, there's copper. I mean, there are lots of different minerals in there.
I didn't realize that. So that the extracellular matrix makes up like 30% of the bone, roughly, correct? So when you talk about how bone mineral density only predicts like 44% of fractures in women and maybe 20% of fractures in men, is that because it's only looking at the bone mineral density and it's we're not doing anything to test that kind of, extracellular matrix that is so important to bone health?
Correct. That's absolutely right. The bone density test is an X-ray, and the X-rays from the machine go through the bone and they bounce off the minerals, and only the minerals. And so the machine detects that angle of called the refractive index, and makes its calculations and spits out a number or various numbers on the test, giving you T and Z scores for your bone density numbers. And yes, that's why it only predicts 44% of women with osteoporosis who will break a bone and only 21% of men. Unfortunately, that is almost exclusively what the conversations in a doctor's office focus on, are improving that number on the test instead of working with the patient holistically to actually talk to them about fracture risk and reduce their fracture risk. And a bone density test is only one piece of that puzzle.
Yeah, one of the questions we got leading into this was like, what's the difference between osteopenia and osteoporosis, and how do I know where I'm at on that scale? I know it's only a small part of the picture, but I know people will want to know, hey, if I'm getting the test, what does this stuff mean to me?
Right.
Can we do a quick little kind of snippet on that, and then we'll talk about the downfalls of some of those tests too?
Absolutely. A T score compares your bone density to the bone density of somebody of the same race, sex, who is in their 20s, 20 to 29 years old. So if I'm a 65-year-old, white woman, my T score would compare my numbers to a 20 to 29-year-old white woman. A T score of -1 to -2.5 is osteopenia. A T score of lower than -2.5, -2.8, -3.0 is osteoporosis. And there are some limitations to that. So, for example, it's not for premenopausal women. It doesn't work. There's not a reference range. If you're below a certain age, there's no reference range. So there are some limitations to that. And then there's another number that's on the test called the Z score, and that compares your bone density to somebody of your same race and sex of your same age. So it's a little more apples to apples and a comparison. And that's important because that is helpful for um, understanding where your bone density is relative to somebody of your own age, and can indicate secondary causes of osteoporosis. So, for example, in women, if and the general recommendation is that the Z score is lower than -2.5, anybody should be evaluated for secondary causes of osteoporosis, meaning not caused by just a natural aging process, a loss of estrogen with menopause, with cellular senescence as people get older in their 80s and 90s, and their bones just aren't working as well as they used to. And so there are ways to interpret this that are unfortunately being missed even by clinicians, because that Z score is quite important. And oftentimes, even in 30% of postmenopausal osteoporosis cases, there are secondary causes going on. And I hope we'll talk a bit about medication-induced osteoporosis, because that's one of the most common that I see. And that's missed by most.
And that's one of the big questions is like when we start to look at some of this stuff, I think there's probably a range of how aggressive somebody needs to be in terms of, certainly prevention. I think once we get to, kind of the point where we are osteopenic and osteoporosis, if already talking about how important this is, I think if you're in that category, it's like be as aggressive as you possibly can with these, kind of changes that we'll get into here. But I think it's the people who don't know where they fall on that risk standpoint that maybe they're not exercising as much as they should. Maybe they don't have the perfect diet, but they're like, look, I'm living fairly healthy. Do I need to start to ramp up this thought of like, hey, I'm 50. I feel pretty good. I haven't had major fractures. Is this something that I should be paying attention to? And how strongly, how aggressively should I be paying attention to it?
So I think people should be paying attention to it even younger than that. But unfortunately, even in the Medicare age population, 65 years and older, 95% of eligible patients in that population who are eligible for a bone density test, that osteoporosis screening test, are not getting tested. So it's not, and it's up to the primary care physician. They're typically the gatekeepers then for the testing, for the assessment, for the treatment, and they are woefully underprepared and feel this way. There's a study that's published showing that doctors really are confused about how to approach this. They're not trained to have the more in-depth, subtle conversations around diet, lifestyle, supplements. They're really not sure about the medications, which ones work, safety profiles, that sort of thing. And so there's a lot of confusion even amongst medical professionals, which makes it imperative that patients educate themselves and really advocate for themselves. Unfortunately, the first symptom of osteoporosis oftentimes is you break a bone. Something happens and you break a bone, and that's often when people finally get screened. And even people who break bones are not getting screened often enough. And this gets into some of the nuances of the screening guidelines published by the U.S. Preventative Services Task Force versus the Bone Health and Osteoporosis Foundation and other associations. And the U.S. Preventive Services Task Force does not recommend, it's not part of their recommendation that somebody 50 years or older who breaks a bone, they get tested. Where it is part of the Bone Health and Osteoporosis Foundation recommendations that if you're 50, man or woman, and you break a bone, get a bone density test.
Yeah.
So, and there are other differences too that are important clinically, but people, I think it's in their best interest to pay attention to their bones earlier, because when they say, first of all, I hear this all the time, I'm eating healthy. But what does that really mean? Most people say they're eating healthy when I do a diet recall with them, when I quantify how much protein they're eating. And by the way, protein, the amount of protein you're consuming can account for 2 to 4% of bone mineral density. So most people, despite the keto diet craze, the paleo diet craze, high protein diets, are not eating enough protein. And in fact, the U.S. recommended daily amount of protein or daily allowance for protein is insufficient as people get older to maintain bone health and muscle mass, to maintain strength and reduce your risk for falls and fractures. In fact, 95% of fractures occur because somebody falls. So anything we can do to prevent falls can necessarily prevent fractures and other fall-related injuries.
So let's go back to that for a second. So 2 to 4% of your bone density can be directly related to your protein intake.
Correct.
Is that and for you to go from hey, I have fairly healthy bones to osteopenia means that your bones are, if it was minus, are 10% weaker than what that test than the, I guess the standard 20 to 29-year-old is that. So like almost half of that could be coming from inadequate protein intake that gets you into an osteopenia state. Does that make
I've seen
sense?
repeatedly people when I'm working with them, they're doing different things and their bone density is not budging, and they increase their protein intake, and that boosts, and then their bone density goes up. You can't build any tissue if you're not giving it adequate amounts or the right types of the raw materials for the body just to do its job that it's naturally, programmed to do, and that it wants to do. It's like a car that if you don't put gas in the tank, it's not going to run. But as soon as you give it gas, its biochemical processes, our enzymes, our machinery, it's ready to go. It wants those nutrients. You just got to feed it the right way.
Yeah, I've likened this to like, you're building a house and all the workers show up, but there's no wood, there's no material there. And they're like, well, we responded to the stimulus. You called us, but there's nothing here for us to build with.
I love that. Yep.
Before we go to get kind of deeper into the reversal and what we can actually do and how much can we change this, can we talk a little bit about the parathyroid, vitamin D, calcium cycle that happens to affect bone activity, so to speak?
Yeah, but the parathyroid hormone, which is here, and parathyroid is your thyroid gland is at the base of your neck, and the parathyroid gland is four little distinct, circles of tissue embedded in the thyroid gland that secretes one of the hormones is parathyroid hormone. And that increases calcium retention, reabsorption through the kidneys, so you're not excreting as much out in the urine, and it enhances calcium absorption in the intestines, along with helping with vitamin D, and that provides a net balance of helping to promote and improve bone density. So but the parathyroid hormone, if it's vitamin D is low, parathyroid hormone can be high, and so it can be a secondary cause if your vitamin D is not high, if not in the safe, healthy range.
Yeah, and I think that's where we started to look at vitamin D for patients, because if they didn't have the vitamin D present, then they were going to have a tough time absorbing calcium through diet or supplement form. And so we can't actually go back to reinforce the calcium in bones. I think like 99% of our body's calcium is stored in our bones. So it seemed like that was kind of one of the leading things of if we're having trouble getting that calcium to where it needs to be, maybe it is vitamin D that we need to test and check.
It could be, and the reference range, I like testing for vitamin D. The research points to healthy for maximal reduction of fractures, hip fractures specifically, a vitamin D level of 30 to 44 nanograms per milliliter, and that's pretty easily attainable, even with just taking 2,000 IUs a day of vitamin D3. The interesting thing is, and it goes back to this bone density story, that bone density is not a fantastic predictor of fractures, that you see an increase in bone density when vitamin D is as low as 9, so 9 to about 30. And so but you don't see that maximal fracture risk until you're higher than that. And so that's where that story that you can't just focus on a number on a test, you've got to think about, or I encourage people and doctors to think about clinically, what is it that we're trying to prevent? What are we actually trying to prevent as the outcome? We're not just trying to change a number on a test. We want to prevent people from breaking a bone.
Right, right. Don't move the number up and then the person still has a fracture and they still end up in that high risk where look, you may have 25% risk of dying over the next year.
Well, and that was one of the frustrating things for me that really opened my eyes and got me interested in this. Back in 2006, I was in my clinic and working with patients, and I thought I was doing a great job. Their bone density was going up. My mother-in-law has osteoporosis, and she had her her physician she was working with, she was taking Fosamax. I was working with her with some nutritional and supplement recommendations, and her bone density was going up. And I thought I was doing a great job at the time, and her doctor did, and she did, and her number was going up. And so everybody thought she was protected, but she wasn't. She tripped on a throw rug in her house, which is common. Those area rugs that she shuffles, and people can shuffle especially as they get older, fell and broke her hip. And so I thought, what is wrong with this picture? By all objective measures that were tested, she should be doing great and not have broken a bone. And the reality is that's when I discovered that bone density testing is not actually a fantastic predictor of fracture risk. And there are so many other things that are better predictors of fracture risk, frankly, more predictive.
Yeah, let's go into that a little bit. If somebody's listening to this and they're like, "Look, I've had my bone density scan and I came back, I'm on the low end of normal, um, but I want to know everything about this." If you could set up the perfect testing protocol and check everything that we would need to check to really predict somebody's risk, what would that look like? What tests are we running? What should we be checking? What attributes are we looking at?
That's a great question. I wish that existed.
Right.
So the state of the research and where we're at now, there really isn't a suite of tests or a series of tests that I can point to where I can say, if you just change these numbers, you're protected. It's going to reduce your fractures, your absolute fracture risk by X amount.
Right.
It doesn't exist. There are many tests out there, and they're commonly run and ordered. And frankly, doctors are applying and telling patients that they're protected by improving the numbers on these tests. And that may or may not be the case. So let me give you an example. There are lots of what are called bone turnover markers. So a bone turnover marker are metabolic products that are released by bone or bone cells, osteoblasts or osteoclasts, during their normal activities of bone remodeling, breaking down old bone, building up new bone. Osteocalcin, which I mentioned, is one of those. There are other ones. There are probably a dozen of them. There's C-telopeptide called CTX, N-telopeptide, NTX, which are associated with collagen breakdown and production, respectively. There is what's called P1NP. There is, just dozens. I can't even, off the top of my head, I don't use them that often because they're not that great. The state of the research currently is that there's no real standardization across labs. There's no standard reference ranges. They haven't been validated. There are lots of things that can interfere with the specimen itself if it's not stored properly, if you exercise the 24 hours prior to getting the blood draw or your urine taken, if you're a woman, depending on the phase of your cycle, if you have other systemic diseases, and the list goes on and on. And that's before you even had the specimen taken, the blood or the urine taken. And then it has to be stored and processed in a certain way, has to be processed within a certain number of hours, depending on the specimen. And so there's just not, the landscape is not great for utilizing these tests clinically. But there are, of all of those tests, only two are recommended by the International Osteoporosis Foundation and the National Foundation for Laboratory and Clinical Chemistry, and that's the CTX test and the P1NP test. So if anybody's going to do any testing, those are the ones, but not for fracture prediction. They have a caveat in there with the testing. It's really to look and to see if somebody's compliant with treatment. One of the nice things about bone turnover markers and the advantages of it is that you can test them more frequently than a bone density test, which is only run about every 18 to 24 months. You could do it as early as maybe a year, but typically it's 18 to 24 months because it's not that sensitive at detecting changes in the bone density. Bone turnover markers, because they're byproducts of metabolism, will change in the urine and blood faster. So you could test them every 6 weeks, 3 months, and track those changes. But is that really predictive of fractures? No, not
Yeah.
really. It may help somebody feel good. And where I use it clinically is if somebody really is important to them, some people are motivated by that number on the test. They want to see those numbers. That's helpful. I mean, that's clinically useful to help people become more engaged in their health and to show them, yes, what we're doing is working, because it's hard to know, if you've got to wait 2 years to get another bone density test and you want to see, am I changing? Some people, they don't love that.
Yeah, they want the scoreboard. I feel like even something like if you did like a weighted like muscle strength test would be a pretty good predictor of bone health. Like if we compared your strength to body weight ratio compared to your age group and younger, it seems like that would at least be up there. Like if we stacked some of those things in together and you said like, here's your bone health, but here's your strength to body weight. Do you think has that been done? Is there studies around that?
Yeah, that's an interesting question and idea. I've never thought of that concept, and I haven't looked for studies there. I don't know if there are or not, but it makes me think of, will that actually, excuse me, indicate improved bone health, or will it simply indicate reduce risk for falling, which is important? So as I mentioned before, there are other better predictors of fractures. And in fact, gait and mobility is a better predictor of somebody's fracture than a bone density test or any of the tests, really. And that's, can you get up from a seated position unassisted? How fast do you walk across the room or down the hallway? Are you steady on your feet? Those are better predictors, frankly, than any test.
Yeah. Yeah, that's where I go with when I'm like, if you could, if I'm taking my mom and I'm like, hey, look, let's really find out where you're at. If I was just carte blanche, hey, you can do what you want. I'm like, look, I still want to see a DEXA. I'd look into some of the newer tests there, but from my standpoint, it's like, okay, let's do a really in-depth balance test. Let's find out where you're at from a strength perspective, single legs, one side to the other, testing a bunch of different muscles. Where do you fall in that? Are you in the top 25% of your age range? Are you in the bottom 25% of your age range? Probably looking at nutrients, nutrient balance just for sake of knowledge. And if there's something that really jumps out, like we've talked about, vitamin D, maybe vitamin K, K2. So like that's where I would start. Are we off base there?
No, I think you're absolutely right, and I love your approach. And as a physical therapist, I think you get it better than most healthcare professionals. That is the strength of the body, the structural integrity of the body is crucially important. Not only with this disorder, not only with osteoporosis, but it also is a predictor for all-cause mortality. If somebody, I believe it's you probably know this better than I would, but leg circumference is associated with more early mortality. The ability to stand on one leg for I don't know how many seconds, is it 10 seconds or 15?
I think it's 15, but
15 seconds. That's a predictor. That's associated with dying if you're not able to do that. So, and all-cause mortality means from all causes, including osteoporosis, heart disease, whatever it is. So yes, I mean, I think that's a great approach. I just wouldn't, and I think we'll probably talk about specific nutrients at some point during this, but I do want to plant the seed that you mentioned vitamin K2. Vitamin K2 is a category of nutrients. There are different types of vitamin K2 within that. They don't have the same level of research or effects on the bone and other parts of the body. So it is important to understand which type of vitamin K2 that you're taking, because there's only one type of vitamin K2 that's been shown to promote healthy bone density and maintain bone strength, as indicated by reducing the number of fractures in clinical trial volunteers.
Yeah, don't let me forget to come back to that because that is very interesting to me. I feel like that happens a lot where we lump all of these forms of a vitamin into one research category and start putting out research, and it's not really telling us what we think it might be telling us. But
Well, what's fascinating to me is even when you start looking at the research in PubMed, the National Library of Medicine's database, these peer-reviewed studies, I've had to email the lead authors on those studies because they don't define in there which form of vitamin K2 they're using, either in the animal study, the human clinical trial, or even in review articles. They will just start talking about vitamin K2 as though it's the same thing. And there's a story that I'll get to hopefully that is a bit pet peeve with the National North American Menopause Society's updated osteoporosis guidelines. There's a little section on vitamin K2 that really got my hackles up.
well, look, we had Dr. Barry Tan on here. I don't know if you're familiar with his work on vitamin E, but we had the
Mm-mm.
same thing where you start researching vitamin E, and it says the exact same thing. Oh, here's what vitamin E did when we supplemented it.
Right.
Well, then you start tweezing that out. And I had to do the exact same thing. I had to email to find out what type of vitamin E did y'all give. And when you actually got into the nuances, tocopherol, which is a very common supplement of
Yeah.
vitamin E, either does nothing or may have some slight little negative health implications unless you're very low. But the tocotrienol version has lots of robust health benefits, but that's not even mentioned in the research of what type.
Right.
It was just like vitamin E. Even if you were doing a meta-analysis, that meta-analysis could be on two different types of that. And you're like, this is not telling us anything. This is not telling us any good information. Anyway, we'll carry on.
Yep. We get it.
So let's go to who, like the who with this. You talked about let's doing it earlier. There was one study that I went and looked at that was I don't know, it was like in 2010, and it showed that children who had it put like negative lifestyle implications, which I would assume is malnutrition, low activity levels, all of these things that we talk about that are negative to a health complication. They, at the age of 10, will be about 20% lower than their like kind of healthy, little kind of cohort. At 20, they'll be like 30% lower. And so it was like you see the graph. I'll put the graph in the show notes for everybody listening. When you see that graph, you realize that like if we start getting off track early, we're setting ourselves up to be that person who at 50 is osteopenia or osteoporotic. And so like when you see that, I'm like, okay, we need to pay attention to this way earlier than the person who ends up in the office with the fracture. How does someone identify that in themselves or their family members of who is at I guess greater risk, but also who needs to be the most aggressive with the activities that we're going to talk about?
You raise a really important point, and that is that osteoporosis is really a pediatric disorder with geriatric complications. And it can start early in childhood. The peak bone mass, the peak bone mineral density occurs between 20 to about 29, in their 20s, which is why a T-score on a bone density test compares somebody to a person in their 20s, because that's when peak bone mass is achieved. And so as kids, we're trying to make sure that they're getting adequate nutrients, adequate activity, and avoiding things that damage bone to get their peak bone mass as strong as it can be, as high as it can be, because what we know is that typically, and again, you can build bone mineral density and bone mass even after you've lost it, but typically what happens is that after it's hit that peak bone mass, people start losing bone density at about 0.5% per year. And then for women in menopause and for the 10 years after menopause is the fastest rate of bone loss. So there are things, not getting adequate calcium and vitamin D when we're younger can reduce the ability to get that peak bone density as high as it can be in our 20s. Exercise. So there are cells in the bone. I mentioned two, osteoblasts and osteoclasts, but there's also osteocytes in the bone, and those have mechanoreceptors on there. Those mechanoreceptors respond to shear stress on the bone, mechanical stresses on the bone. When people, children or adults, running, jumping, whatever it is, kids doing gymnastics, playing soccer, that's stimulating the bone cells into activity to build more bone. So one of the challenges that I think we have now that didn't have when I was a kid and younger generations is kids are getting outdoors less and they're on their screens more. They're not participating as much and just running around the neighborhood. I know when I was a kid, we were told, get out of the house and come back when the streetlights come on. That's how I grew up and loved it. Now kids are not doing that as much. And so that I would say is a risk factor that if it's not, I haven't researched that or looked in the literature if it's popping up yet in the pediatric literature or not, but I imagine it will if it hasn't as a risk. But the number of hours on screens, I would say, or the lack of outdoor activity. Definitely sedentary lifestyle is a well-documented and understood risk for osteoporosis. Eating disorders also that can show up, that do show up in children and adolescents. That is a risk factor for osteoporosis. And you mentioned malnutrition, and that would fall within that category, putting somebody in that malnutrition state.
Yeah, the scary thing, because you hit it right. Like, you do see a decrease in physical activity among kids. And I remember, this is kind of random, but during COVID, after those first few weeks where everybody was kind of struggling to find something to do, we were driving through our neighborhood and saw like a group of neighborhood kids playing basketball outside, and we paused from it. Like, we were like, look at that. Like, they were all outside. And then we talked about how weird that is that we noticed it. Yeah. Like, that shouldn't have been something that we noticed. But the problem with that is that we might not know the implications of this for 50 years. And this is kind of the oops of the kind of food pyramid and stuff. It's like, sorry, we messed that up, but now we affected the health and the lives of millions of people. Sorry, we should have told y'all that was a problem back then.
Yep.
So let's go through. You talked about reversal. How much can we change this? Like, if I'm already there, I'm 50. I've got a T-score that says I'm osteopenic or osteoporotic. How much can we reverse that curve of that downward trajectory?
I can't quantify that for you, but I can say that repeatedly I hear from people and I see how numbers have gone from osteoporosis to osteopenia. They've improved, or osteopenia to nothing, or even from osteoporosis back into the normal range without even having osteopenia anymore. So I think it depends on a lot of factors, but it is definitely, people are able to improve that number on a test. And that's important. But again, I go back to how actually predictive is that of fractures. Yep. More importantly, people are not breaking a bone. It's hard to prove a negative. Like, how do you prove something doesn't happen? But the clinical trials are very clear when it comes to nutrients in terms of falls and fractures. There are certain things people can do that can grow bone, healthy bone, and promote healthy bone, so that when they do fall, their risk for breaking a bone is reduced.
Yeah, so you talk about in your book kind of basically, I guess, the 4 sections people need to pay attention to fracture-proof bones, being diet, lifestyle, nutrition, supplements. Let's double click on each one of those. So let's go diet. We talked about protein already.
Yeah, there are actually 5. So
Okay. Did I
diet,
miss one?
lifestyle, exercise,
Exercise.
or I guess more nutrients if you want to do that separate from the supplements. So that's four. Then there's sleep and there's connectivity, community connectivity. So I guess that'd be six. That's on what you can do proactively. On the other side, though, people want to identify, it's important to identify risks and things that are damaging bone and get those out of your life if you can. And that goes back to very common medications that people are taking, and other things, environmental factors that increase the risk for falls and fractures, is correcting those as well. So it's the old story of, you can't exercise away a bad diet. So if you're still putting stuff into your body that's creating damage, you can only take your health so far. It's like pushing a boulder uphill. It's just going to keep rolling right back down. So you want to change the landscape. You want to change the environment within your body so that what you're doing proactively to build bone can be more effective and longer term. And that includes, importantly, and I'll go back to it because it is such a blind spot conventionally, is evaluating the medications you're taking.
Let's go through that. What are the big ones? What's the things people need to be looking at?
So the common ones that doctors know about are the glucocorticoids, like prednisone, and about 1 to 2% of the population is on chronic glucocorticoids, prednisone, dexamethasone therapy, and that's quite common. That's been shown to increase fractures by up to about 200%, and so that's well known. But a couple that I keep going back to that are not so well known are the proton pump inhibitors, the acid blocking medications like Prilosec, Protonix, even the histamine 2 receptor antagonists have also been that category of acid blocking medications also associated with fracture risk. But people who take proton pump inhibitors for 4 years, it's associated with a 60% increase in hip fracture risk. In fact, in 2010, the FDA issued a warning letter about proton pump inhibitors all the way back in 2010 about that they could increase the risk for osteoporosis and fractures. And the FDA never approved these for long-term use anyway. And so people are just taking them. They're available over the counter. And so that's a huge blind spot. Most doctors aren't aware of that. And that's a problem. And in fact, with dietary changes, you can actually correct most of the or many of the cases of acid reflux, which is the predominant reason why people are taking acid blocking medications. And so, in fact, well, I won't go into belabor that point too much. The other category of medications that are the antidepressants, any antidepressant that raises serotonin artificially. So the selective serotonin reuptake inhibitors and the serotonin and norepinephrine reuptake inhibitors, your Prozac, Wellbutrin, sertraline, those sorts of medications. Those damage bones so much so that meta-analyses have shown that women taking them for 1 to 5 years, for every 19 women taking them, we'd expect one to break a bone. And so that's a huge blind spot as well. There was a study done that looked at people who entered the hospital with osteoporosis and a fracture, what they were taking in the 3-month medication, 3 months prior to breaking a bone, and they categorized the different medications. And what they were taking them after they left the hospital. And there was no net benefit, meaning the doctors who identified which some of the medications were causing problems, like prednisone or phenytoin, the Caesar medication, or other medications, they switched them perhaps to a different medication, but also put them on other medications that increase the risk for fractures or falls or osteoporosis. There was actually no net benefit, even when they were hospitalized. But it's just an important thing to be aware of. And there is a long, I'm just barely scratching this. So there's a long list of medications. I mentioned phenytoin, but aromatase inhibitors are commonly used for breast cancer, androgen deprivation therapy used for prostate cancer, any of the chemotherapy, so it's a long list. So evaluating your medication. There's a whole chapter on that in my book.
So with that, if someone's on that, is it to start to make a plan to get off of those and get those out. I mean, you talk about those inhibiting your progress. So even if you were doing the right thing, you're like, I need to start to pull these out, and start to work with your healthcare practitioner to come off the glucocorticoids, or, to come off the SSRIs if you can come up with a game plan that's healthy to do it.
The goal would be to take, and I think should be the general goal about medications anyway, the lowest dose possible for the shortest amount of time. So it's inevitable. Some people are going to need to be on medications chronically, but many times they can't. I mean, from a holistic standpoint, looking at depression, which for the SSRI medications, there are many ways to deal with, from a functional medicine, naturopathic medicine perspective, integrated medicine perspective, and look and evaluate depression that can have amazing benefits. And so looking at that holistically may allow, and I've gotten many people off their antidepressant medications using these holistic approaches. The other thing too, if somebody has to be on an antidepressant, there are ones that are safer. All medications have side effects, but for example, the tricyclic antidepressant medications, those are not associated with osteoporosis and fracture risk. So there just may be safer alternatives. And with the proton pump inhibitors or the acid blocking medications, simple dietary changes often can take care of that acid reflux. Or maybe
Let's
they've
go.
got H. pylori, or they need to be tested for that and they haven't been. I mean, they're different things.
So let's keep going down that pathway of kind of active changes that somebody can make. Is there other dietary changes that you would have people start to build on other than paying attention to protein?
Absolutely. So the question, and I keep going back to this like a broken record because it's so important. The question is, which dietary pattern, if any, has been shown to, most importantly, reduce fractures? The only dietary pattern that's been shown to do that is the Mediterranean style diet. And that is essentially a plant-forward diet with lean proteins like fish and chicken. Yes, there's some red meat, but lower than what we eat, and less amount and less frequently than what we eat in the United States. It's essentially the opposite of the standard American diet. Very limited amount of packaged foods, lots of whole grains, and that's been studied. I've never seen any negative study on that. 70, 80, 90 years. And is associated with not only a 20% reduced risk of osteoporosis, but a 20% or 21% reduction in hip fracture risk, which is amazing just by the food you put in your mouth. I mean, we all have to be eating. So you're making choices every day. You're either, feeding your disease or you're promoting your health with every bite of food that you take in. The diet that is recommendation that I found in the research is sort of lacking in there, though, is quantifying the amount of protein somebody needs. So I've adapted that diet, and I go through it in my book to make sure not only to help people transition into eating that way, because it's so different from the standard American diet, but how much protein based on your body weight should you be consuming a day from different sources. And that's an important component to give your body the whole, constellation of raw materials that it needs to do its job, whether it's for bones or heart health or brain health or muscles. It's all interconnected.
What's that? I know that's a range and probably kind of depends a little bit on activity, but as a rough guideline, how much protein should people be trying to work into that diet?
Yeah. A minimum of 1.3 grams of protein per kilogram body weight per day. And that's based on the research and the clinical trials. So that's about, if you take your body weight in pounds, I believe the conversion is about multiplied by 0.54, or I'd have to do that. I haven't done that conversion in a long time. But if you just take your body weight and divide it by 2.2, that'll convert it into kilograms. And then you multiply that by 1.3. That is the number of grams of protein you should be consuming as a minimum per day. Some recommendations go up even higher to 2, more for bodybuilders and that sort of thing, 2 grams per kilogram body weight per day. For example, my protein intake, I should be getting about 90 grams of protein a day based on my body weight. And I have a hard time doing that always, so I will supplement. And I'm a big fan also of using dietary supplements as the FDA intended. That is, as a supplement to a healthy diet. So diet is first, it sets the foundation, and then supplements come in to push your body to make up the difference where you can't get it, where that's supported by the clinical trials to help.
Yeah. Do you agree with collagen supplementation to get the protein and the collagen? Do you
So
like some of that?
technically, collagen supplements in the United States cannot be marketed as a protein dietary supplement because it's not a complete protein. It's
Yeah.
missing one or more amino acids to make it a complete protein.
Right.
There is definitely protein. Collagen is a protein, but it's not a protein dietary supplement. The clinical trials on collagen are clear. It does promote healthy bone density. It's good for joints. It promotes healthy, skin hydration and elasticity. Yes, I am an advocate for collagen supplementation. In fact, I created one specifically for bones and skin because of the strength of the research. There are no fracture outcome studies on it. But again, in terms of the hierarchy of evidence that I look for, that's number one. Are there clinical trials showing something reduces fractures in prospective clinical trials? If not, are there studies, epidemiological or cohort studies showing an association with reduced fractures, as the endpoint? And then secondarily, has something been shown to promote or improve bone density, or has something been shown to improve that bone turnover marker that I mentioned before, like CTX, and collagen actually also does reduce CTX on blood tests as well.
Nice. Let's go into exercise. I know we're going to kind of spot some of these things, but by all means, like this is super important to get all of this information. Like, go get fracture proof. I think this is so important for everybody, but I really want to talk about exercise because I think it's one of the bigger things that again kind of gets a lot of these things going in the right direction. So what's a good exercise program look like on this program if we're trying to structure exercise around bone health?
Great question. The best exercise that somebody can do for themselves is one that they're going to do consistently and that is safe. That's the best exercise routine. So for some people, that may look like just starting out, walking. If you're not
Yeah.
really, if you're living a sedentary lifestyle, it's clear in the research, multiple studies now have concluded that if you just walk an average of 7,000 to 7,500 steps a day, that's associated with a 50 to 70% reduction in all-cause mortality. That's death from any cause, including osteoporosis. It used to be, and I still hear it, you got to walk 10,000 steps a day. Whenever I hear statements like that, I'm just wired to ask the question, can you show me a study? What's the study? Well, for many
Yeah.
years I asked that. Nobody could show me any research. I searched for it. I couldn't find it. I discovered that recommendation was created by a watch company in Japan out of thin air because they were wanting to sell more watches. Right? The research shows that the benefits in terms of all-cause mortality plateau at 7,500 steps a day. So for me, 10,000 steps a day always seemed, daunting. But yes, I can do 7,000 to 7,500 steps a day on average, and it's cumulative. It doesn't have to be all at once. I mean, you can take baby steps here, park one row or two rows farther away from the door at the store, at the market, or across the parking lot. Take a stairs instead of an elevator. Just walk around the block. There are lots of things, even just that simple thing. Another simple thing I like to teach is the stork exercise, and that is stork stand on one foot. They're famous for it. So while you brush your teeth, stand on one leg while you're doing the bottom teeth. Just switch to the other leg while you're doing the top teeth. And 1 minute for the bottom, 1 minute for the top, 1 minute per leg. You can balance a little bit with your hand on the sink if you need it, but that'll help, increase a little bit, work a little bit of your stabilizer muscles in your legs, your adductors, your abductors, a little bit of your abdomen, just improving that stability a little bit. All these things, just around your own house, you can do exercise. And of course, you can go to a gym, but not everybody loves to pump iron, it's not safe for everybody necessarily to pump iron, or maybe they can't do it because they have arthritis. and they're just not able to work out in a gym, or maybe they just don't like it. Lots of things. There's a Pilates, gentle yoga, and you've got to be careful with osteoporosis because certain exercises can actually increase your risk of fractures if you have advanced osteoporosis. Certain stands, you don't want to do headstands in yoga. Pigeon pose, where you're putting a lot of that stress on the neck of your femur, could be a problem for some people. PVALD is a functional training. There's the OsteoStrong program. Like, there are lots of things with vibrational plates and resistance exercises. Lots of things that people can do. And resistance exercises are important because that puts stress and strain on the attachment of the muscle on the bone. And that mechanical stressors that I mentioned before, they're mechanoreceptors or mechanical receptors in bone. That stress, the muscle pulling on the bone, is a signal to the bone to build more bone. So it's important to have some resistance, but your own body weight is resistant. Every
Yeah,
time you go to step up, if you're 150 pounds, every time you take a step up a stair, you're lifting 150 pounds on that one leg, right? So there are
right.
different ways to think about this that I think can be helpful.
Yeah. Yeah, I was trying to figure out if they had done good studies on different types of exercise to see if certain exercise improved, bone mineral density, and we've talked about the problem with using that as our success marker, and pulling a bunch of different studies. Basically, what it seemed to show is like the more you work your muscles, or the harder you work your muscles, the better your bone mineral density is.
Correct. And there are
Go
studies
ahead.
that have looked at bone density as the endpoint. Uh, I think it was Tai Chi, yoga, weight bearing exercises, lifting weights. Those all can improve bone density and reduce the risk for falls. The challenge is there's a lack of studies out there in exercise with fractures as the endpoint. It would take
Yeah.
about 7,000 participants in the study to be powered high enough to detect fractures. So there's only one study that I could find, and I included in my book, that had it. It was an exercise study that looked at fractures, and it was with women, and they had them do one of four different exercises, flexion, extension, and then they were able to see which type of movement. And when I say flexion, I mean laying on the ground and doing sit-up type motions, or you're sitting in a chair, and this is literally what they had them do, and bend forward, or laying on the ground as an extension and do, if you're familiar with the kind of Superman pose, with your arms back and your back arched a little bit like this, laying on the floor, doing that, or doing it in a chair. And what they found is the biggest risk for fractures was the flexion exercises, which a lot of people is their default. They're like, oh, I need to do sit-ups. I need to work my core.
Yeah.
And yet that actually, in this one study, increased the risk for fractures. And I think part of the reason for that is, and this isn't a specific demographic, this is in women with osteoporosis, but I think the reason for that is that people tend to sit hunched over anyway. And that, you can see people with osteoporosis, they get the hump in their back called the dowager's hump. And that puts more pressure on the anterior sections of the vertebrae and increases the risk for anterior wedge fractures. Now you combine that with people on their phones all day, like this, right? And I think you increase the risk even more. And so then when you're doing those sit-ups, you're doing those flexion exercises, you're increasing the pressure on the anterior part of your vertebrae as well. And I think that's probably a pretty good explanation for what's going on.
Yeah, I like that. So would you take the leap to, the 40 to 65-year-old listening to this, like, okay, no matter where you're at, start doing some weight training, start training some extensor muscles, train your pulling, train your extensions, train the, extending the hips, extending the back, rowing, have that stuff in your program to start to at least take steps toward prevention.
Yes, if they want to go in a gym, if they want to lift weights. But frankly, look, you're in Louisiana. So, someone wants to go out and chop some wood, or they want to garden, all of that is super healthy. to do. Natural movement,
Yeah.
functional movements, things that move our body in the ways that it was designed to move. One of the challenges I have with working out in a gym and lifting weights is it isolates muscles and joints in a very unnatural way. And so the risk and it can be healthy. I used to lift weights and love it. I'm 56 now. I don't lift weights anymore. I do all functional exercises. But I also used to rock climb, and I used to ride my bike commute to work, and that sort of thing. It's again, I think it's a similar concept or idea with diet. I don't look at just one food. I look at the dietary pattern. I don't look at just one part of movement. I'm like, what are you doing throughout your day? What's that pattern look like?
Yeah, I like that because I mean, from my standpoint, I do wonder if somebody has a significant risk for this, how much they could reverse without having significant weight training somewhere in there. It's like, look, you don't have to do it every day, but once a week, you probably need to get in there and move something fairly heavy. But it's more about the whole, how do you change every part of your life rather than thinking, hey, I went and spent 30 minutes in there. I don't have to do anything else. So I love that mindset shift probably is bigger. Like, don't think that you have one golden ticket to this. You need to change these multiple areas to actually make a dent in
Well,
it.
and if you say, and I just want to clarify, when you say weight bearing exercise, are you thinking about lifting weights in a gym exclusively?
I think anything that makes you strain harder than you think you should.
Absolutely. Yep. Yoga can do that.
Yeah.
Qigong can do that. Tai Chi. I mean, yes, absolutely. You and I are on the same page.
Look, I got invited and went as a guest to a Pilates class, and I was the youngest person in there was probably 80, and I finished drenched and like muscles shaking. And if you ever want like humble pie, have like an 85-year-old come and like tap you on the back and be like, "Look, just stick with it. You'll get better. It gets a little easier." So absolutely, if they're doing that, I promise you, she was not. She improved her health to the degree that she at least minimized her risk for fracture.
Absolutely. Again, 95% of fractures occur because somebody falls.
You mentioned like vibration therapy. Are there any other things that get you excited on that front from like a technology standpoint?
No, I mean they're not really. I mean, I think there was
Okay.
something. Unfortunately, they're not here anymore near our house. There was yoga on vibrational plates, and then fortunately through COVID, it went out of business. I was doing that for a while, and that was an incredibly difficult workout. There are lots of ways that people can do this, and I'm also a big fan too of not being stuck in your ways. Like just have fun, try different things. The best
Yeah.
exercise is the one that you're going to do.
Yes, yeah, I like that. Let's go back. We kind of hit our little supplement soapbox there. Let's jump back to that for just a second. So let's dive into a little bit of the K2 issue there.
So it's a category. So vitamin K
Right.
itself is a category of different molecules. The two subcategories are vitamin K1 or phyloquinone, which is found in green leafy vegetables, and vitamin K2, which itself is a category. And it has different types of vitamin K2 in it. They're designated by numbers. What people will see in dietary supplements typically are MK4 or MK7. The number, to just get a little technical, each of those vitamin K molecules has a side chain on it. The length of the side chain, the number of carbons in the side chain, called an isoprenoid subunit, that is the number that refers to the number in the name of the molecule, or the name of the nutrient. So MK4 has 4 carbons in the side chain. It's shorter side chain than the MK7. Now, what we know in biochemistry is that if you change one carbon atom, you get different results. You get different effects on our biochemistry and physiology. Like a Venn diagram, there is overlapping responses biochemically, overlapping actions in the body that MK4 and MK7, but there are also separate things that they don't both do. So when it comes to bone health, and which one is better, MK4 or MK7? From my reading of the research, it's the MK4 form in the dose of 45 milligrams per day. The reason why is there are multiple reasons why, but when it comes to actual clinically what's happening, MK4 in the dose of 45 milligrams per day is the only form of vitamin K2 that's shown to both improve bone density in clinical trials, but more importantly, reduce fractures, that is, maintain strong bones, as indicated by over 70% fewer fractures in clinical trials. In contrast, MK7 in different doses in which it's been studied has been shown to only slow down how fast somebody loses bone density. And there are no studies showing that it actually reduces fractures. It's fascinating to me, and I get these questions from people all the time, and what's out there on the internet. MK7's better because it's more bioavailable. It has a longer half-life, meaning it stays in the body longer. So I only have to take it once a day instead of multiple times a week. Therefore, it's better. So that's how companies are marketing this nutrient and this very inexpensive, frankly, commodity in the dietary supplement world that people can manufacture very cheaply. So they can put out cheaper stuff and say, oh, vitamin K2 and bone health. It's had better bioavailability, meaning it's absorbed better, and it's got a longer half-life. Well, those are test tube studies. That's not clinically the most important thing. Again, hasn't been shown to reduce fractures and improve bone density. Only MK4, only in the dose of 45 milligrams a day. There have been so many studies, over 25 clinical trials, that has been approved by the Ministry of Health in Japan since 1995 for bone health. And at least five of those studies actually looked at fractures as the endpoint. There have been multiple meta-analyses done, and they've concluded that indeed MK4 promotes healthy bone density and reduces fractures in postmenopausal women with osteoporosis. They're also, unlike MK7, clinical trials using MK4 in medication-induced osteoporosis, showing that, for example, with glucocorticoid therapy, it stops the bone loss caused by glucocorticoids. From androgen deprivation therapy, the same thing. And so, and it has other health benefits as well. MK4 is the only form of vitamin K2 shown to promote healthy cell division. They're up to phase 2 clinical trials with different types of blood cancers like myelodysplastic syndrome, acute myeloid leukemia, also with liver cancer, showing health benefits. The body accumulates vitamin K2 as MK4 in different tissues, the breast, the pancreas, the testes, the brain, and the intestines, pointing to a larger health role than just for bones. And it doesn't do that as MK7. MK7, the body does not accumulate MK7, it accumulates MK4. And we have the machinery actually to convert part MK7 to MK4 and vitamin K1 to MK4. But to get the amount that you need shown in the clinical trials to work, you need to supplement your diet. You can't get it from diet alone, with a dietary supplement that has the 45 milligrams of MK4 per day, which is the reason why I started my company in 2007. I went back to what happened with me and working with people with osteoporosis. And there was no product on the market that existed that had the clinical dose of the nutrient MK4 with calcium and vitamin D on it. So I started a company because I needed to help my patients. And it's just, grown from there. And this would be a good point, though, to point out that, look, these are dietary supplements. They're not medications. Like, they're not approved by the FDA to diagnose, treat, prevent, or cure any disease. What they do is, based on the dosages used in clinical trials, they powerfully promote somebody's bone health.
Do you take MK4?
So I personally don't. I'm 56 years old. I'm not on any medications that would reduce my risk of increase my risk of osteoporosis. I exercise regularly. I mean, 5-6 days a week. I follow the Mediterranean diet. I get enough sleep, an average of 7 to 8 hours a day. I'm connected with my community, all the things that I do. And so, and I've not broken a bone. If I were, I'm 56. If I were to fall and break a bone, I'd definitely get a bone density test at this point. As a man, I'm at lower risk anyway for osteoporosis. 80% of osteoporosis cases are in women, only 21% of men. There are other supplements I take, but I'm not taking my Osteo-K or Osteo-K Mini product. But my father is, because his doctor has him on Prilosec. and he started to lose bone density. And my wife is, because she's 53 and now perimenopausal, and her mom had postmenopausal osteoporosis. So she takes Osteocare Mini. And so for that reason,
Perfect.
I take.
Yeah, that's exactly why I was asking. I think people listen to that and somebody's like, "Well, I'm gonna just take it anyway." Like I'm 40, but even at that, like I have a patient who's she's in her 40s, early 40s, fit, healthy, exercises, and yet had a non-traumatic foot fracture, just kind of out of the blue, fractures the bone, doesn't seem quite right. Like you didn't do a whole lot. Let's let's get a DEXA and take a look at what's going on with this. And comes back and it's not terrible, but it's not perfect either. So for somebody like that, to me at that early age, it sounds like, hey, you have a higher risk. Should we start looking at doing, the
Yeah,
extra
I
things?
love that you brought that up because it really gets also into the interpretation of the test. So at 40 years old, and I imagine she's still getting her period, is that correct?
She may be just on the other side of that. I'd have
At
to
40, that's
have to
awfully
dig
young
into
for
that.
menopause.
She's like mid 40s,
Still
but
younger for menopause. But
yeah,
even so, if she's not postmenopausal, the T score is not valid. You've got to look at the
yeah.
Z score. So,
Hmm.
it could be secondary causes going on. She may not be eating enough protein. There may be other things happening, but
You probably hit the nail on the head there. I think we've had that discussion. If you're listening to this, pay attention. Doc knows what he's talking about. Um, so, like to kind of put a bow on some of this stuff, you, if you can absolutely change it if you are osteopenia, osteoporotic, doing the things that we talked about. If you're not there and you have a family history of your parents had a fracture, you've had a fracture that wasn't traumatic, then start paying attention to these things and looking at these different areas because the earlier you start, the more ground you can make up. Is there anything you would layer on top of that? Put the sprinkling on top of it?
I think that's a great summary. I would just add that what I do with patients is when they come to me, they've got a bone density test that shows osteopenia or osteoporosis, and they're scared. They've been told by typically their physician that they need to take a medication. Sometimes they've been pressured to do that. And I just tell everybody, take a breath. Like, this isn't an emergency. There is time to educate yourself and put together a holistic program that makes sense for you. And medication may be part of that, but it may not be.
Yeah.
And so that's one of the purposes of my book, Fracture Proof Your Bones, is to lay out for people what they can do, how they can create this holistic bone health plan for themselves and ask their doctors questions so that they're making the best healthcare decisions for their own health. And so the bottom line is it's not an emergency. You can take a breath and there's time to put together a plan for yourself.
Doc, finish that last line for me, just in case.
Starting with what?
He's like, what was
Okay.
it? Just from take a breath.
Yeah. I said it twice. So the second time I said it?
Okay.
Yeah.
Yeah. Yeah.
So take a breath. There's time to put together a holistic plan that makes sense for you.
Love it. Doc, I've got so many notes on this. We could keep going. There's so much into it. It's a very intriguing topic because I love that it's like kind of the tip of the iceberg. You start digging into it and there's a lot that's related to bone health and it affects so many different areas. So you mentioned the book. Where can people follow you? Where can they get more information about bone health? Where can they get your book? All the fun stuff. They want to follow up and take more action on
The
this.
best place would be my website, nbihealth.com. NBI stands for Nutritional Biochemistry Incorporated. So nbihealth.com. All the information, resources, book, products, blogs, lots of free articles, links to social media are all there on the website.
I love it. Doc, we ask all of our guests if people listening to this could do one thing to improve their health today, what would that one thing be?
Increase your expectations of what is possible for yourself. Demand more of yourself. Demand better.
That is a very good one. I love it. Dr. John Neustadt, thank you so much for joining the show. This was fantastic. I really appreciate everything you're doing and putting out in the world. I know a lot of people are getting help from taking these actions and changing it. So thank you for doing all
My pleasure.
that.
It was fun. Thanks for the opportunity.
All right, folks. Thanks for listening to the Pain and Performance Podcast. And if you are not watching this on YouTube, you will definitely get more from checking us out over there. So if you didn't catch this episode, be sure to go and subscribe to the YouTube channel. And we will be uploading all of our episodes so that you can get a visual of what's going on. And you definitely kind of get different brain stimulation when you're watching the conversation. Dr. John also wanted to pass along a discount to any of the supplements that they have over there at Nutritional Biochemistry, and you can use NB10 to get a 10% discount on anything from them. So make sure you take them up on that, especially if you fall in those categories where we need to get the proper form of K2. We need to get all of the extras that we need to improve our bone health. So without further ado, I will talk to you next week. Have a great day.